add more hours to it, but maybe they'll give them 4 or 5 hours. What are family caregivers supposed to do who are working, who are depending on these people to take care of their clients? Everybody's going to get an in-home worker, and that's supposed to save money? I mean, the logic of this thing just keeps... I don't understand how we've gotten this far on this plan that doesn't make any sense. The other thing is MSSP, okay? MSSP, case management. What do case managers do? Case managers go out and find services, like us, like adult day health care. So if you wipe out adult day health care, where does the case manager go scrambling around to find the service that the person needs? You can have all the managing you want. If you don't have the care that people need, what's the point of managing care? I don't really understand the logic behind the whole thing. And I know that our legislators are concerned too, because this is not what everybody signed up for. And I'm trying my darndest to figure out, okay, how can we work with managed care to maybe get some of the case management funded? How can I get this piece funded here, there, and everywhere? And I'm ping-ponging all around trying to figure out the resources when the resources were put there in the first place. So explain to me how you can spend $85 million, of which the state was also going to get $85 million more dollars because you were getting one-for-one match, and you're not necessarily getting that in the $85 million that you're going to spend ongoingly. Maybe you will in some way, but it's not clear. You have no financial trail, no nothing. We can't operate that way. I don't understand how you're letting this happen. It just does not make sense to me. And I think we have to be creative. I think our association has been very willing to be creative. We can find other funding sources because there isn't enough money. Let's go about that. But dismantling this system of care doesn't make any sense financially. It doesn't make any sense to our clients, socially speaking, and it doesn't make any sense medically. You do not know when somebody's going to need the nurse. But if they're in a center, the nurse will be there. You do not know when they need therapy or when they're going to have a stroke, but they're in that environment, you're going to be able to check it out. You're not going to be able to schlep people all over town and get this kind of care, and you're not going to save any money. So honestly, I just don't understand why we don't stop it right now and get a grip and figure out what really needs to occur here. But you know, the deed is done, and we're really concerned about the fact that we did lose the Medi-Cal benefit, but there may be other ways that we can fund this program and figure it out. I'm up for that game. I'm really tired of playing this transition game. And I've told my clients we're not going anywhere. I don't know what it's going to take, but we're not going anywhere because they need this service, and we need to keep it going.
Thank you, Ms. Davis. I don't exactly know how to respond. So maybe the best thing to do is to continue with the panel, and then we'll come back for committee members for questions or comments. Mr. Friedman.
Good afternoon. I'm David Friedman, kind of a tough act to follow. I feel like a newcomer. I'm with HealthNet. I've only been there 26 years, so Kathy has me beat by a couple of years. We're one of the state's largest health plans for both Medi-Cal and Healthy Families. We serve almost 1 million members. We serve nearly 1 in every 4 Medi-Cal members, beneficiaries in a dozen counties, and about 140,000 Healthy Families and Healthy Kids and AIM members. We also, in 20 counties, we also offer a robust dental program for both Medi-Cal and Healthy Families. And I'd rather point out differences, or just add on to some of the things John said. Unlike San Francisco Health Plan, though, we are also a Medicare plan. So we have the opportunity to enroll these members into our Medicare plan where we have Medicare coverage. Our coverage service area is almost from Sacramento to San Diego down the Central Valley, almost contiguously, including Los Angeles, as Toby mentioned. We are working very closely with the state and with LA Care in Los Angeles, where the lion's share of these beneficiaries are. In addition to the weekly calls that the department has with all plans, we have a second call just for Los Angeles with the department and the county to work through issues. In addition, both LA Care and HealthNet are hoping to contract with APS to help us through this transition so that we'll be using the same contractor as the state. Those conversations are going on. We have a meeting with them on Wednesday. I had a meeting with them today. By doing that, we hope to get a jump on the health risk assessments, because if both LA Care and HealthNet use the same contractor, we can start them earlier than October 1st. As someone mentioned, the 45 days is not a lot of time to do something like 20,000 assessments in Los Angeles County alone. We're very committed to collaborating with our partners in the state and with LA Care to get this done right. We have also been working with Lydia and her staff both up here and in Los Angeles on a very regular basis. We believe that one of the things that has come up obviously is an increase in in-home supportive services. Hours is essential to this, as is the MSSP issue that was brought up earlier. And then in the interest of time, just to address one other issue about the cultural nature of this population. Like San Francisco Health Plan, HealthNet translates its materials into a dozen different languages ranging from Arabic to Vietnamese. And we will do that for the adult day health centers because we realize that they are much like the Medi-Cal population in that most of, or a large percentage of them are non-English speaking. And with that, thank you for the opportunity.
Thank you, Mr. Friedman. Ms. Toth, my Kathy Davis.
I'm going to be calm and cool and collected today, just so you know. Kathy and I flipped a coin before the hearing, and she got to be the advocate, and I'm just...
Your time's up.
Yeah. Good afternoon, members of the committee and Chairman DeSaulnier. Thank you again for having this hearing, and thank you, Assemblymember Yamada, for joining. So my name is Debbie Toth, and I'm the Chief Program Officer for Rehabilitation Services of Northern California. We're a nonprofit agency serving Contra Costa County, and among our programs that serve seniors and people with disabilities, we have 2 adult day health care programs, a multipurpose senior services program, and the California Community Transitions Project. It's my goal today to provide some clarity in my testimony regarding the inadequacy of the state's plan to transition people out of ADHD, show the many questions that have gone unanswered in this process, and highlight the greater immediate budget impacts of over simply funding a waiver program or any other program. So the basics of the state plan are as follows, and I'm going to kind of go over testimony, and I'm also going to kind of respond to some things that have come up today. So I will present you with my testimony, but there's going to be some ad-lib in between. So, okay, so back to the plan. So all Medi-Medis will be enrolled in managed care. MSSP will increase around 2,000 slots. IHO waiver will have 500 to 1,000 new slots. PACE sites will increase their capacity. SCAN will serve Los Angeles and Orange counties, and APS. So also IHSS, but I'll get to that a little separately. So first and foremost, let's go back to the Medi-Medis being enrolled in managed care. The forced enrollment of 35,000 dually eligible patients into managed care is unprecedented. The 1115 waiver process clearly demonstrated and unveiled a heavy resistance to enrolling this high-cost acuity population, high acuity, high-cost population into managed care. As a result, there are only 4 counties which will be piloting this enrollment. The pilot is to determine what works, what doesn't, and how to best plan for the future and ensuring a smooth transition with adequate and cost-effective services. Now the administration, on its own, has decided they will utilize the frailest subset of this population on which to test the efficacy while concomitantly removing multiple skilled therapies and activities from their daily routine on which they rely. Managed care, and please don't take any offense. Bad grouping at this table here. It's not about you. So managed care will be unable to meet the needs of this population without adult day health care to offer daily on-site skilled interventions. Many managed care organizations will acknowledge this fact behind closed doors, but must say what they need to say in public because they don't have a choice. This is mandatory enrollment, and they're agents of the state. They will be absorbing a population of Medi-Medis through an adverse selection process, taking on the neediest and most chronically ill with an enhancement of approximately $60 per month. The problem with managed care is not in coordination, but rather in total lack of ability to purchase the necessary services. I'm working very closely with the Contra Costa Health Plan, and believe me, this unfortunate situation that we're in right now, that's such a light word for it, but I mean, we actually talk to our managed care providers, which is really great. We have this relationship. However, They've been incredibly frank with me about their inability to pay for the services we offer while acknowledging that there's a need there. So I'm grateful to be able to work with them on a limited basis to provide intensive case management, but that's not going to provide daily nursing care. It's not going to provide the therapies, and it's not going to get the positive health outcomes of what they would get in a congregate setting with other similar services. So I'm grateful to have that in place. It's not going to keep my center open, being realistic. So MSSP, I'm talking about MSSP as one of the solutions in this transition plan. I'm also the site director for MSSP in Contra Costa County, so I'm very familiar with what MSSP can and cannot do. And yes, care management, I wouldn't quite make it as simple as you made it, because it's not, but it is care management. It is not direct services. It is not in a congregate setting. It's a minimum of a monthly phone call and a quarterly visit. It is not the same. There's not the same service happening. So in this proposal, in this transition plan, MSSP will be raised to less than its level of 2 years ago. So we've sustained funding cuts twice, and we're now going to be restored 2,000 slots, which don't equate to where we were 2 years ago, to the baseline. So MSSP will make, okay, I went through what they did, sorry. The administration's assumption that MSSP can purchase ADHD-like services is also not realistic. At the Contra Costa MSSP, the average amount of waiver service dollars, that's the purchase of service dollars that we have in MSSP, per client is approximately $80 per month. So we're doing better than you are with your $60. But paying for just 1 day of adult day health care-like services per month would not allow us to purchase them a personal emergency response unit. We wouldn't be able to purchase in-home assistance for them, transportation to and from their medical appointments, and the list goes on of the things that we couldn't purchase for them if we wanted to purchase 1 day of adult day healthcare-like services. There is also the issue of the waiting list, and I guess I heard today that we're all going to take our waiting lists and put everybody on the waiting list who's been waiting for services who are skilled nursing eligible today back in line because the people from ADHD are going to come in front. And I don't know if that's legal on a waiver program, but this is an issue that we as MSSP site directors, I haven't heard a word of it until being in this room today. The IHO waiver serves an extremely frail subset of the population, and granting between 500 and 1,000 slots, the state has yet to explain how they will operationalize this. Will they be able to enroll 500 to 1,000 people in less than 30 days? Is the state staffed to review and approve or not approve thousands of applications? And even if the state could do this, how do they decide who gets the few slots? So is this geographically determined, or does it first come, first serve, or is it based on differing acuity levels of this population that is the most compromised out there? So how does that work? And I just want to say, you know, IHO is this waiver that serves an incredibly medically fragile population, and it has to be cost neutral. So it cannot cost any more to be in the in-home operations waiver than what they're paying today for their current Medi-Cal services. So that's an awesome program for people coming out of a skilled nursing facility, like we do with the California Community Transitions Project, because it's expensive to be in a skilled nursing facility. So you can purchase all kinds of services coming out of skilled nursing and going into the IHO waiver and living in the community. Going from being in adult day health care, a very cost-effective program, to going into the IHO, you're going to have more expensive purchase of service and be able to get less bang for your buck. PACE sites will increase their capacity to what? They will not be statewide. I mean, we don't have it in Central, South, or East Contra Costa County. As heard in the testimony of Tracy McLeod in the Assembly Long-Term Care Committee hearing, their agency had both a PACE and an adult day health care, and when they closed their ADHC, only 2 out of 57 people qualified and were willing to go into PACE. If it is this difficult for an agency who runs a PACE and can best explain and encourage participation in the program, what will it look like at the centers who do not have a PACE and cannot offer the comfort of it being offered at their own agency, something familiar? Change is not easy for any of us, but particularly hard on this medically fragile aged population. In fact, this kind of change for people with mental health issues or dementia can cause immediate and devastating decline in their condition. SCAN is in Southern California and while it may be an outstanding program, it's not all-inclusive and has many of the same gaps in service as any managed care organization when compared to daily attendance and adult day health care program. And honestly, I don't know much about SCAN beyond that. APS is to assess and refer all ADHD patients not living in managed care counties. If we, providers of services who have been in the business of caring for a medically complex and frail population, cannot find services in our areas because they don't exist, I can assure you an agency unfamiliar with the area and population will fare no better. Additionally, what safeguards are put in place when they don't find services? And if a referral occurs, is it followed up on and ensured that the service connection is made, or are they just referring? Here you go, call IHSS. And then they're done. They've done their part. They assessed, they referred, they're done. Each of these cobbled together programs costs money. Has the state analyzed the cost? Well, I guess this came up a lot today. The state analyzed the cost of these services coupled with the cost shift to institutions, emergency rooms, acute care facilities, and the state's unemployment. So let's look at all the pieces of the puzzle at once. And I refer to this because we're in a budget committee hearing, and I think that this is what you talk about here. The reason of record behind the elimination was to achieve a budget savings, right? As I see it, the state is effectively paying more money to fragment care, remove services, and divest our state's most vulnerable of their very, very basic right to live in the community with independence and dignity. So, give you a little snapshot of Contra Costa. 3 nonprofit ADHCs, no other ADHCs, 3 nonprofit ADHCs who all operate on a shoestring budget relying on community support grant writing to keep their doors open. So it's not like the state pays us all kinds of money and we're rich, believe you me. Together, the 3 ADHCs serve over 85% Medi-Cal population. 2 nonprofits are the only congregate settings which serve veterans. So what are the veterans going to get when we go away? 2 nonprofits have a contract with the regional center and are the only health congregate settings to serve this growing population aging into chronic conditions such as Alzheimer's disease. They cannot be served in social day models for the DD population. One family already placed their mother in a skilled nursing facility because they see the writing on the wall that there won't be enough beds available when the only 3 centers keeping people at home close their doors. So somebody's already in a nursing home right now because of the threat of the elimination of this program. And is there going to be other mass flight to skilled nursing facilities for people who don't belong there? The health plan is already contracted with these ADHCs to provide intensive case management. However, that alone will not keep our doors open. We need financial assistance, or over 100 years of combined experience and infrastructure will wash down the drain, and that's just in Contra Costa County. So I want to tell you about one of our participants. His name is Rich. He's been attending for just under 10 years. He today is 63 years old, so he was in his early 50s when he began coming. He suffered 2 massive strokes, which left him confined to a wheelchair early in his life. He also has diabetes, hepatitis C, suprapubic catheter, and cardiovascular disease. His sister took him in and became his sole caretaker. He could not bathe himself, toilet himself, or care for himself. She did it all. And her husband couldn't take that she wasn't giving him enough attention and gave her an ultimatum that it was either him or Rich. She chose Rich, her brother. That was 10 years ago. She struggles to work during the day to get enough money to pay for rent and hers and Rich's needs. She is his sole caretaker and IHSS worker. She has no more time to offer him and still be able to pay for their rent and their food. She relies on ADHC to keep him at home. He relies on ADHC for his life. Through daily nursing, physical and occupational therapy maintenance groups, food that is for his diabetic diet and his cut served on a heavy dish with a metal bar with a raised spoon on a dicem so he can feed himself. He can barely move anymore, and it is the physical therapy and constant exercise which allows him to have that one last luxury in life, feeding himself. If you ask him what he gets from coming to the center, he will tell you exercise and help. But what is most important from his perspective is having friends and sharing a life that he didn't have when his wife and friends abandoned him after a stroke. He will be placed in skilled nursing when we close. And this is just one story. There are many stories like this. And I think that we need to put on the brakes just a little bit here. You got the 6-page letter regarding concerns from the managed care organizations who are the crux of this. I have a letter from the IHSS program manager in Contra Costa County. Dear Chairperson DeSaulnier and honorable members of the committee, this letter is intended to convey my concerns regarding some of the thinking and planning that is being bandied about regarding how IHSS is going to impact the persons and families who are being victimized by the closure of the adult day health care program. As the program manager for IHSS in Contra Costa County, I assure you that the services IHSS provides cannot possibly make up for the closure of the ADHC facilities. The ADHC and the IHSS programs are both wonderful programs that serve a very vulnerable population, helping this population to remain in their own homes, functioning as independently as possible. These two programs offer a safety net to clients and their families. Each program offers different, unique services that, when combined, truly add to the quality of a person's life. IHSS is not intended to make up the services that ADHC offers, nor can IHSS make up these services. ADHC offers a congregate experience for persons who benefit tremendously from the opportunity to socialize with others for 5+ hours a day. The skilled services offered at ADHC, such as nursing, speech and occupational therapy, and case management, are specialized services happening at one location. The IHSS program does not have these capabilities. The IHSS program authorizes services that help individuals complete the basic activities of daily living, eating, bathing, toileting, etc. Many of the IHSS services are provided by family members. In our county, I estimate that as many as 20% of the persons served by adult day health care and IHSS will need to be placed out of their homes because family caregivers will simply not be able to put in all the hours needed to keep their relatives safely at home. I respectfully and urgently ask you not to place these persons out of their homes. IHSS can offer more hours when there's been a change in condition, and I can promise you there's going to be a change in condition after they're kicked out of their adult day health care programs. But they will have already had their assessment, because in the transition plan, the assessment happens before they leave the adult day health care program. So now you're placing the burden to get 2 separate assessments for the same person, and you're going to be adding hours up here and hours over here. And let's be realistic, we're not really going to be adding hours over here. We're going to be adding increments of minutes. How long does it take to feed them? How long does it take to toilet them? How long does it take to fold their laundry? Those are the things that are going to happen. They're not going to get protective supervision, and let me tell you about my Alzheimer's participants. That's exactly what they need. If they don't have that protective supervision, only 3% we heard in Toby's numbers today. You think they're doling out protective supervision? It is the most expensive part of IHSS and the hardest to get. These people will end up in skilled nursing facilities, and there's not enough of them. We are rushing into a plan that is robbing us of our moral and our financial responsibilities. Thank you.
Thank you, Debbie. Our last speaker.
Last but not least, hopefully. Thank you for the opportunity to speak. My name is Bob Edmondson. I'm the chair of the California PACE Association, and also I'm the CEO at ONLOC, which is the prototype for PACE, the Program of All-Inclusive Care for the Elderly. I'm not going to speak for a long period of time. I'm not going to critique in detail the transition plan. For those of you who don't know, ONLOC was a founder of the ADHC program many years ago. So we have been full tilt in support of the effort to sustain the ADHC movement. We recognize the passion that you've heard today is well justified. The problems that we expect are well documented. So what I'm here today to talk about is a little bit of what we can do. We're there to try to help. We're working with the department. We're working with the ADHCs. So if bad things come to pass and people have no place to go, at least PACE can help out to a degree. So let me just briefly state what PACE is. Most of you are quite aware of this, but it's important because it does differentiate our clientele from that of the ADHCs. PACE serves individuals 55 years of age or older. They have to be in the service area of the PACE organization, and they have to be certified by the state to be nursing home eligible. So the majority of our folks, and I'll give you the average for the 5 organizations, 79 years of age, 14 diagnostic diagnoses, 13 to 14 prescriptions, 3 ADLs, activities of daily living. So you're talking about the frailest of the frail, not different from some of the ADHC folks as well. PACE is unique in that it does integrate Medicare and Medi-Cal funding. It is a capitated program. I hesitate to call it managed care now because I'm a little nervous about that, but it has that flavor to it. So the design is to be efficient and to provide excellent service and high-quality care. So that's the goal. It's been around for a long time. I like to use the word proven model because we are all in the midst of a lot of experimentation with different approaches to solving the financial and healthcare crises that are coming down the pike. Real quickly, what is our status? As you know from what was said, we're not everywhere. There are 5 organizations that provide care in multiple counties, essentially in Los Angeles, San Francisco, Alameda, and Santa Clara. And we have 2,800 participants, so we're not in the thousands and thousands of folks that you hear. What we believe is, and I've been polling our members to see what are the available slots. That seems to be an important issue. And what we think we have right now is about 900 possible slots available for ADHD folks and others. It's important to remember that. There are 1,400 that would be added to that if we can deal with some of the efforts of our member organizations to expand and create new sites. One of our members does have existing ADHCs, that's Altamed, Senior Buena Care, and the Altamed Corporation, that they are trying to transition in. And in the written remarks that I've given you, you see some of the totals by county that are available. So what would I say? I think that we're in the transition plan. I think we're seen as a partial help. I hesitate to use the word solution because we're in difficult times. It isn't a solution. It's something that can help, and that's what I would say. Remember, those that are in the ADHD programs right now, under 54 years of age, those who are at risk of and are not nursing home eligible, this is a different group. Also, PACE is voluntary. This is not a mandatory enrollment environment. People can choose to go in and out on a monthly basis. There's no hooks. People don't leave, but it's just important to realize this is a different animal. So let me just mention real quickly 3 things that we think would help. Toby's heard these a few times, but it is extremely relevant in the current environment with the velocity of change that's occurring, which does worry us as it worries the ADHD folks, to say the least. First, we need to expedite the processing. We're talking 45 to 60 days to get into a PACE program. Well, you heard some of the time frames today. That's past December, let's face it. So that is not helpful. We believe that the department is receptive to our efforts. We've proposed what's happening in other states right now that will facilitate rapid enrollment. It needs to happen. And it needs to happen with or without the ADHD crisis. It makes no sense when people need what we offer to have such a restrictive environment and length of time that they have to wait. I hate to complain a little bit, but essentially the notification process to the SPDs, to the ADHD folks, and hopefully not for the duals, has been less than great for PACE. We're minimally mentioned. We've asked the department to reflect on that if they think we're part of the solution, or at least something that's helpful. We need a little more visibility. I know we're not everywhere. I know it's a voluntary program. I know it's not mandatory. But the problem is, if you're not visible at all, it doesn't make any difference, all those other points. Okay? So that's something that needs to happen. Shortly, we're going to have an executive director, and he will be relentless in sharing space with Toby for sure. But it's important. This notice issue is not minor for us. It's a major problem, and it's been in existence since the SPD started. And Assemblyperson Yamada put on a hearing to talk about this, some of these issues in addition to rates. So all of you are pretty familiar with this point. It's important. Last, we need to talk about streamlining the application process. How tough can it be? If one of our members were here, he would say, how tough is it to read 70 pages? How long does it take? 150 days or what? You may have heard him speak. I would submit not long. Why? So we want to see that process improved. And the example that comes to mind is the change of some of the ADHD sites that want to become PACE centers. So we need to look at that. Also, PACE is popular. It may seem like in hard times it's crazy to talk about new programs or even existing programs, but it is popular. There are 4 organizations in the wings hoping to become PACE in California. There are 79 nationwide, and there are probably 15 or 20 in the wings on a nationwide basis. So this is something that does offer a little solution to some of these problems in the country and certainly in California. Thank you for your time.
Thanks. Questions or comments? Ms. Yamada?
Well, I certainly, as a guest here in the Senate, I don't want to always be the first questioner, but since you gave me that softball.
Okay, yeah, we'll move on.
Actually, before I get to some questions for the new panel, I did have maybe a question for Mr. Douglas. And by the way, magically, your letter to all of us just arrived on my space here, so thank you for your response. I'll be reviewing that in just a moment a little more closely. But how did the decision to contract with APS and SCAN get made? I mean, this is sort of like, in my mind, is somewhat of like a sole source contract, that there are contracts being let to organizations that must have been within your administrative purview, but I just want to point out these two organizations because of some other concerns. I know that Controller John Chung has raised about SCAN and its alleged 80% profit rate, and then I know that APS, which again may not have anything to do with our contract, but was recently fined $13 million for fraudulent Medicaid billing. Could you explain how these two organizations came into contact with us?
Sure. Well, I'll start with just reminding the legislative action that was taken to eliminate the benefit and was requiring the department to ensure a transition to other services. So again, everything is within that context of our goal to transition to other services. That statute also gave the department the authority to do grants, to contract as necessary on a sole source basis. It's been our responsibility to take the steps on. I mean, again, I just have to remind we're balancing a fiscal reality with trying to move fast. So I'm having to take steps that, yes, in the real we wouldn't be doing. And one of those is on the fee for service. We needed to make sure that there was a system to assess. And it had to be, we were eliminating a benefit, we needed to look separately, and we had a contractor, APS. So we're using them. We have strong contractual requirements on what they have to do, and we'll be doing that. Now, on the SCAN front, first, just to make clear, SCAN is just like PACE, is one of the alternatives in terms of managed care options. Or organized delivery options, if PACE doesn't want to be called managed care. And they are not, it's not that we're suddenly contracting with SCAN. They have always been an alternative for those in certain geographic areas to receive integrated Medicare and Medi-Cal services through an organized delivery system. There has been a lot of issues with the financial payments to SCAN in the past. And we've taken really strong action to fix that. First, the rate setting. We have dramatically dropped the rate by over 70%. So what we pay them now is a rate that aligns with the cost of doing business. The past, we are working closely with the Department of Justice, both at a state and federal level, to resolve the litigation against SCAN, to get the money back that SCAN was that they were overpaid, and bring that money back to the state. And we expect that to be resolved in the coming months. But from a care standpoint, and their quality of care has always been good, continues to be good, and it's important in this transition plan to provide options. And SCAN is one of the options. Just as those who choose to be in fee-for-service, we need an option to make sure they have coordinated care, and that will be APS. So it's alternatives, but SCAN, we're going to continue to hold them accountable, make sure that their costs are aligned with the cost of doing business. They give us cost reports, and we get the money back from the past.
Well, I'll just do a quick follow-up comment. It just seems to me that if we are in a position to contract with other organizations to provide similar services, it's unclear to me why we wouldn't contract back with the existing centers that are already proven. But I'll just put that to the side. Just a quick question sort of for anyone here from the managed care plans. I'm certainly, as we all are, aware of the 6-page letter that has been issued with the variety of concerns. Would any one of you be willing to say where you are in the process of having those 6 pages of concerns addressed? And if you're not comfortable, that's fine too. You know, we can certainly have other conversations.
Sure. Would say that given the weekly conference calls that we've been having, we have been working through them. I think there were direct questions asked earlier about the withholding of some of the $60. I think that one we're still working on.
Well, okay, I understand that. Oh, go ahead.
Sorry.
I'm sorry.
This is not unusual, as Toby would probably acknowledge. The department will send out a new policy or whatever, and plans will have questions. I mean, this is part of the normal process. And then we use that to work through all of the issues. And as John mentioned, most of them are being resolved. There are some that are still outstanding.
Well, I also heard at our other hearing in the Assembly that, the $60 amount that's been thrown around is not set in stone. And that I also heard Director Douglas say at our hearing that he would be able to spend, or he would spend whatever it took to get these services in place. However, I'm sure there's that finite amount of $85 million that might make that a little difficult. That would require the legislature and the budget committees in both houses readdress and reassess the situation that we're placed in. I just wanted to close my comments for this portion by saying that I thought the most enjoyable testimony that I've heard thus far in this entire process since the July 25th veto has got to be from Ms. Davis, who, I think, frankly, is saying a lot of what we would like to say. And that is, and I've already said that my vote was a mistake in this context. I would have never voted I don't care if I was the only no vote and, other consequences inure to people who don't go up on a budget vote. But that's a vote that, I would not have taken had I known. I think that it's important for the administration, and poor Mr. Douglas here has, heard me say this in a variety of settings. He has the unenviable position to implement what the legislature enacted absent this budget understanding that we all had. And that, I would again reiterate that I hope that the highest levels of this administration are paying attention to what we are saying, that this is a mistake. This is high-speed rail that is not the kind of high-speed rail that we want to support, that this member does not want to support, because this is a mistake that I think if people were willing to admit to the mistake would alleviate a lot of the disaster that I think is unfolding before us. We can all try to put on a happy face and say that we're doing the best we can, but to eliminate and destroy a 30-year-long infrastructure that is proven at the same time that the silver tsunami is at our doorstep, I think this is a very tragic public policy mistake that is going to require courage on all parts of the government to address, and address very quickly, because we are not going to be able to replace this infrastructure quickly enough. I stood up on the Assembly floor a couple of days ago to, on behalf of Senator Evans, undo the MorphoTrack cameras to fingerprint IHSS recipients, because we found that those $5,000 per camera costs did not support the budget savings that were thought to have accrued from that budget action. I don't think we're going to have 2 years to find out that this is not going to result in the budget savings that we would like to see. And finally, we haven't even begun to address the trigger cuts that are going to affect IHSS, MSSP, PACE, all of these other realities that we are facing. And I hope that we come to the point that the administration at the highest level will be listening to what we're saying, that this is a mistake that we should stop, and stop now. Thank you.
Senator Leno.
As I mentioned in my opening comment, that I came today not yet convinced that where we were headed made much sense. And I have to say that what I've heard today has not brought me any closer. We're in a very difficult position here right now because I don't want to be overdramatic, but a familiar metaphor of a train wreck that we're watching it happen. How do we stop? And I would not want to put Mr. Douglas on the spot to respond to Ms. Davis and Ms. Toth's presentations today because it just wouldn't be appropriate or fair. But trying to focus on what we are responsible for here as part of the Budget Committee. And again, Mr. Douglas, I'm not going to turn to you because your plate is more than full right now. But I think we might discuss, Chair DeSaulnier, of requesting of the Department of Finance to put some of this on paper to get a grip on exactly what the proposal is. How does it spell out in real terms in a responsible budgetary fashion? Because of all of the human pain that can be caused as a result of what we're doing, if we come out the other side and see, as has been suggested, not just here today, but in many other forums, that there is likely not the savings that we had imagined, then what was all this about? I think the Department of Finance owes us at least that. Please put down on paper and show us, as the demands on the $85 million continue to multiply. So that's just a comment as we're in the midst of all of this right now. I have a couple of questions here. I guess first, Mr. Douglas, if you could tell us, where are we in getting the dollar-for-dollar match, federal match for the 85?
Everything we're doing right now in terms of the transition plan, in terms of moving the most vulnerable acute population into in-home operations waiver, to managed care, using our APS, everything is federally, receives federal match.
Matchable.
So we are receiving 85 plus 85 for everything.
Okay, that's good to know. I think it was Ms. Toth who had touched on the discharge planning and additional costs. Does that sound familiar?
I didn't touch on that, but I can.
Oh,
You said $50. What? Yeah, $50 is not
Lydia,
enough.
had you touched on that?
I did too.
Okay. So it's my understanding that it is the ADHC's responsibility to do the discharge planning.
Correct.
Correct. And will you all be able to cover those costs?
Well, it isn't clear yet what the expectation is. We, as an association, as we are proactive, developed a standardized discharge form when we got the letter from the Department of Aging in July that reminded the centers of their duty to do that. So back in July, we were already on that path, and then it wasn't until recently that it appeared the department was contemplating having the in-home operations assessment, not discharge, but assessment form, which is 16 pages, be used somehow as a discharge form on top of that or in addition to the IPC. So that's why I made the comment earlier that it is certainly not clear to me, and it's not clear to our members, what the expectation is in terms of all these additional assessments. It seems like a lot of duplication of effort, and then we have care coordinators that are coming in. We're going to have the plans doing health risk assessments. We need to sit down and kind of map out and figure out what exactly is needed. What is the person getting today? What do they need when they're discharged? And are those services available? Very simple.
And with all due respect, I know that my staff have been working with Lydia and talking to her about that, and that we're going to continue to work through it, and next week we'll hopefully have an answer on what we do. But we know that she's has a discharge plan, and we have Yes, and Mark Helmar has been working with her. So I just want to make it clear this is going on. Everything's moving fast. We're trying to work through it, and we're reaching out, and we'll resolve what the discharge plan should be.
Yes.
There's also the piece that you're still open and operating an adult day healthcare facility and providing services all day long. So I'm not going to not provide services to my clients during the day so that I can sit and write a discharge plan. I can tell you that a very comprehensive plan was done for Rich that I brought with me in case you had additional questions about his care or health concerns. That was about 3 hours to do, dedicated alone staff time in terms of calling the family, ensuring, yes, indeed, he's going to be placed, going through the chart. And he's somebody we've had for 10 years, so we're very familiar with. Some people we've had for 3 months, some people 6 months, some people 9 months. And they're all different ages, and they all go to different services. And so there are a ton of different aspects in just that discharge plan. And, yes, getting clarification on is there one uniform tool, because I am working with IHSS already, because I've told them, if they eliminate us, if we're done and court case done, everything done, there's absolutely no more hope and we're closing our doors, you better come and plant your rear end in here so we can go over everybody's plan and talk about what's going to happen with them. So we are having to coordinate with a lot of partners. So what is this one thing that we can do? And yeah.
Well, and if I could also say, when you do the discharge plan, there's nothing to discharge them to. So you write the whole plan and then you say not available, and you spend 3 hours figuring that out.
And to add to the complexity of this, because there are so many different services that are not geographically distributed across the state in a proportionate manner, how does a center know that what they write on the discharge plan is going to become reality? If there's only so many MSSP slots, if there are only so many IHO spots, if there are only so many PACE slots, you can make all the referrals and write the best discharge plan. It doesn't mean it's going to happen, because I don't even know how the state would even begin to start to figure out how do you match up that specific person with this array of services when they're all limited. So, and then the IHSS enrollment, you can make referrals, and as Deb said, how do you know that referral is going to be accepted? How do you know if it's going to meet the actual need? Because different eligibility, and the providers don't understand all the eligibility criteria. So it's more complicated than it appears on paper.
Thank you. Mr. Chair, I know we have very, very limited time. I want to be respectful of it, but I wouldn't want to miss this opportunity to ask just one last question. And I'll ask it of Ms. Davis. And this is what I hear every weekend when I come home to San Francisco. So it's intense, and I
do my best.
Maybe we could change.
And I thank you for it, because and I'm so glad that you're here. You're here at my invitation specifically because I'm so proud of what you do. And I know the heart and soul and the life that you have put into this. Mm-hmm. This is, and just to back up a little bit, I think we all recognize that when the for-profit folks came into this, there was a real stain and diversion of what adult day health care was established so many decades ago, that there was wisdom in it, mm-hmm. and we did create something that worked. And we're having to deal with that as well. But my question would be, if there had not been the veto, and if you were left to continue your operation with 50% fewer resources, mm-hmm. what would that mean? What would that look like? And I ask this only because this is what the alternative we were trying to suggest.
Well, two things. Even when I heard about it, I knew my clients were more frail, so more than 50% of them would probably be eligible even under the most frail criteria. So that was number one in my mind. I'm thinking, okay, I might lose a few, but they're really pretty frail anyway. Secondly, I would go out and find other resources to keep it going, but at least I would have something to keep my program alive. I would work with my local people. I would look at ways I could fund things differently. That's what I'm doing now, trying to figure out how can I creatively get funding for different aspects of what we do, but I would keep the program together. I would keep it intact, and I would go out and find the money that I needed to find. When we started adult day health care 24 years ago, the reimbursement rate was $17. we in San Francisco had to fundraise to get this program up and running. So I would do what I had to do, but I can't get killed off. And I'm not saying myself, but all these adult day health centers have to have some semblance of money to keep their programs alive so they can continue on. Some can get more private pay. We can go after other sources. You know, over time we can create other, you know, ways to fund it. But when you get the death knell this way and so much distraction over stuff that doesn't even make any sense and deters you out of even trying to get your program together, it makes it hard. But I would survive. I'd figure out a way to do it.
Thank you.
Apologize.
Okay.
Just
Go ahead,
one, this is just in follow-up to Senator Leno's question about asking the Department of Finance for, you know, something more specific. This that you mentioned about the federal match, this is the first time that I have heard that there still exists the federal match. My understanding with the veto of AB 96, because that was the vehicle through which we would have done the step-down program to qualify for the dollar-for-dollar federal match. So to say that we are claiming our dollar-for-dollar federal match to the $85 million that was budgeted to $170 million, this is very new information for me since July 25th. So I am not aware that we have a dollar-for-dollar program match to $170 million. In all of my studies and testimony and analysis thus far, my understanding is we only have $85 million. So I would very much appreciate the clarification from the Department of Finance.
Sure, and I mean, I guess this is the way, I mean, as a single state Medicaid agency, everything that we do when we run money through our managed care, it's all Medi-Cal. If it's a Medi-Cal eligible, it's always drawing down federal financial participation. They're on a waiver or PACE. So I'm sorry, we'd be happy to make that clear, but that was our intention always when we were doing the transition, again, back to the original statute, was about transitioning to other services and maximize federal funding. So, and I would just, you know, we obviously, Debbie and Karen, we have many side conversations. Even if you scream at me, I still want to work with you.
I feel the same way, by the way.
But, you know, we have the in-home operations waiver. You're telling me your population is the most frail, then make sure they go through that authorization process. And 88Cs are a provider type that can be under this waiver. So I really encourage, if you have the most acute, that's what that waiver is there, is to move them into that and to do it.
We can do that, but it's not enough money.
Well, we can talk about it, but that...
Yeah, it's not
But why don't we have conversations to understand that, because it's the same level of payment that that individual is receiving under the state plan. So that's where
I appreciate that, Mr. Douglas.
Sure.
Any other questions or comments? We still have public comment. I just want to thank you all for being here, Kathy and Debbie, and Lydia. I know the passion you bring is something that is hard to measure in terms of an investment, your success in dealing with tough clients. So I do hear from, amongst a number of things that we would like to work with you on, Mr. Douglas, is the timeline on communications, in particular between us, and how we communicate with the broader communities. The questions we couldn't get to today, we're going to get through your website, working with our staff, and then we will do it on our own websites to sort of communicate individually and with the rest of our colleagues. Senator Leno, you suggested that we, you and I guess, ask the Department of Finance to come to us, because and I will just say this in the context of having been chair of two subcommittees now in the Senate, on the first one in corrections and public safety and general government, now health and human services, having sat through with our staff 4 days of grueling public hearings of this budget subcommittee where we cut $6 billion. So we're trying to follow up on all of that transition, and this is a very vocal and important part of that, but we still have a lot. We have DD, we have the TANF funds, really. So in the context, I hope it's not to say that this is right, and in a perfect world, we wouldn't, even a world remotely relating to perfection, we wouldn't be here. We would be using the commitment and the passion that you three bring to the work you do for the clients you have. but we are in a world that's far than less than perfect, both in terms of the budgetary situation we're in the economy, but also how we've constructed this between our legal and political system. And that's not to excuse it, it just makes it very frustrating. Just intuitively, it makes little or no sense to me in the community that I live in, although there are only 200 people in the program from Contra Costa, collectively how you take people out of congregate care where all the research is telling us that there is a definite benefit for people to have these social interactions that are removed from going to bingo at the senior center to having them in their homes with IHSS. And intuitively, in what I've read of research, it makes little or no sense, which, Kathy, you've brought to. So how we deal with that, I guess, is what Mr. Leno is suggesting, and whether this is true savings, transfer, or in reality will actually cost us more money. And having said all that, I've sat here and we do this over and over and over again in different subject areas. Mr. Leno and I have dealt with the Department of Corrections ad nauseum. We in California continue to put money into high-cost crisis services, irregardless of where that California is, whether it's corrections, health services, old people, young people, and we eliminate the lower-cost prevention intervention. I'm not saying it in regard to this program or any particular ones, but as a culture we keep doing this, and it's sort of this self-fulfilling prophecy that things will only get worse because of the result of our actions. So how we change that, I don't know, but I know that with people like Mr. Douglas, I have great faith. I know that you're trying your best, and I know you will continue to. So we will try to communicate better. We will have that conversation. I appreciate all of you coming today. Public comments. As soon as you move, if we could come up. And I do want to remind people we are a little over an hour over, and we didn't get nearly as much conversation as we wanted to, but we're going to continue to pursue it. So if you can be articulate in your comments, if I can say the word, that would be appreciated. Okay. Let's try to keep it to about 2 minutes.
Fair enough. Mr. Chair, members, Gary Passmore with the Congress of California Seniors. We are on public record saying this was the worst policy decision with regard to seniors and elder Californians in a decade. So I want you to understand the context in which my remarks are framed. We fought this every step of the way. The train wreck you're seeing, we saw. We understood what you were going to be hearing here, and one of the tragedies is there was not a full hearing of this issue in the budget process. I've got 2 or 3 concerns. I've got a lot more than that. Most of them have been covered or we don't have time. But let me point out 2 or 3. The first one is, and you just mentioned this, Mr. Chair, there is value in socialization. There's more than just value. Assemblymember and Dr. Richard Pan and Chairman Yamada's hearing talked about how important social interaction for this population is for them to function at maximum physical and mental capacity. And there isn't a single word in the state's plan that deals with the socialization function. It will absolutely disappear unless you demand that there be some provision for it, whether that's in an ADHC or a senior center, something. So that's point number 1. Point number 2 is, I want to remind you of this. It's been sort of discussed. This plan addresses care management, care coordination, assessment, all sorts of things. But it doesn't really address care. Medicare is by and large fee-for-service. So when that 87-year-old woman's blood sugar is dramatically low, does she have to then leave the doctor's office, go to the grocery store, buy a bottle of orange juice, and hope it's up? Right now, she has somebody that can monitor it every couple of hours and make sure that she can be stable. That kind of care will never again exist for this population in the model that you're pursuing. There will not be mental health care services provided because they're carved out of the Medi-Cal managed care plans. There will not be active physical therapy for the stroke victim so that they can function, because Medicare won't cover it, and Medi-Cal, as you heard earlier, will only cover it if that stroke victim's training for a marathon. So, I mean, I'm being facetious here, but the point is these services do not exist elsewhere, the direct care services to this population. And in closing, let me just say that all of our discussion has been focused on finding a place to put 35,000 people who received these services in June. The reality in this state is that we're going to have 75 to 100,000 people who need these services, while all of you are still young enough to know what's going on within a decade, 12 years or so. And we haven't ever had a minute of discussion in this debate about what kind of system we need to have in place to cover that huge growing population of vulnerable, frail elders. Thanks.
Mr. Chair and members, Vanessa Kahina with Western Center on Law and Poverty. We do have significant concerns with the department's transition plan for 35,000 additional people into managed care. We are currently looking and have gone through a painstaking process through our 1115 waiver to transition 380,000 people over the next year from fee-for-service Medi-Cal into managed care. This would be additional to that. Dual eligibles were specifically exempted from that process, so this is another thing that we're going to have to think about. Should we continue to go down this road, we do believe that there's going to have to be a significant amount of oversight in terms of the contracts that are afforded to folks so that we can make sure that people get the care that they need at a price that we can actually afford to pay. And concur my comments with Mr. Passmore. But lastly, just to say that the other elephant in the room is that in the budget process, and we still have so many unanswered questions as to what the feds are going to allow us to do, we passed mandatory copays for folks. So are they going to be paying more if we unbundle services from the way that they're currently delivered in a comprehensive community-based setting? Thank you.
Thank you.
Jack Christie for Aging Services of California. We represent not-for-profit providers from affordable housing at the low economic side all the way up to continuing care retirement communities on the high economic side. This has been a very unfortunate legislative decision to kill off this program. We appreciate you, sir, taking this opportunity, and you, Chairman Yamada, the opportunity on your side to bring this issue up and keep pushing it. We will work with you to try and find an alternative that supports the going forward with adult day health care. It is an absolutely fundamental, basic element of the continuum of care for going forward. And it's the introductory, kind of the basic service. If we don't have that, we're going to be shooting off lots of toes on both foot.
Thank you.
Thank you.
Welcome.
Hi.
You're doing great.
My name is Alana. I am 12 years old. And I came here with my stepmom who works at Adult Day Healthcare. And I have been to nursing homes. I have gone and sung at nursing homes, and it is awful. There is no smiling. Nobody's happy and cheerful. The food is awful. And when I'm an elder, when my grandparents need to go to a nursing home, I don't want them going there. I don't want to go to a nursing home. I want to go to adult day health care. I want to go somewhere where I can live at my own house and I can associate with elders who are happy, not all sad, and I don't want to eat slop. And I don't want my grandmother to be going to a nursing home where when I go and visit her, there's going to be all these sad people and she's going to be sad. I want my grandmother to be really happy and nice adult day health care thing, hopefully where my stepmom is working.
Could you identify your stepmom? You look familiar to me. I know who she is. Thank you for coming.
Thank you.
My name is Peter Bear. I run Guardian Adult Day Health Center. We serve one of the more fragile, low-income, high-minority populations in this state, primarily Richmond and San Pablo. Did a little research. When my father was the state senator, he voted for adult day health care. His name was, like mine, Peter Bear. He made the comment that one of the proper functions of government is to take care of the aged, the blind, and the disabled, those who can't care for themselves. This is what adult day health care does. As the young lady said, if our people, by the way, my standard rule of thumb is if they don't arrive with a smile and leave with a smile, we're not doing our jobs. Now the governor wants to eliminate our program and throw our people into, I'm not sure quite what, just before Christmas. Merry Christmas. The transition plan, which I've read through and considered at length, is a bureaucrat's nirvana. It delegates all the responsibility for doing all the work to adult day health centers, which then they're supposed to walk quietly into the night. County health plans, which at least the ones I've talked with are some of them are apprehensive. In-home support services, you've already heard the letter from the gentleman from In-Home Support Services. I don't think any of them were adequately consulted ahead of time. The second part of the transition plan, again, a bureaucrat's nirvana, is providing inadequate financial and or fictional resources to solve the problems and claim that they're adequate and it's all the fault of the people they delegated the responsibility to, including me, to find adequate services that don't exist for my people. The third part is to throw out a lot of paper, communicate with everybody, tell them how wonderful a job you're doing, coordinating all of this stuff, but still not providing adequate resources. I'm not mad at Mr. Douglas. He's been tasked with an impossible job and is trying to do it. I am mad at the decision, which I think is flat wrong. In Contra Costa County, where I operate, we've met with the county health plan. We've met with IHSS. We've met with a PACE program that covers a small part of our district. They all agree that they cannot take care of the number of people we are putting onto them in an adequate basis, and anywhere near as well as we do. The transition plan is clearly inadequate, is maybe a kind way of putting it, and because it's a mixed company, I won't tell you what I really think of it. Groups particularly not covered at all, as far as I can figure out in the transition plan. Alzheimer's, which is 40+% of our population. I don't know where Mr. Douglas's statistics come, but if most of the people are in LA County, maybe they have a bunch of people who shouldn't be in adult day health. But in Contra Costa County, our people need the help. The other group that's not covered is the mentally ill. 46% of our people who come to our center, have mental health diagnoses. They're kind of excluded from all of the results of this plan. So they have trust issues, among other things, and aren't going to be particularly eager to enroll in a managed care plan. I actually raised this at the stakeholders meeting, was told, oh, it's your job to make sure they trust the health plan and enroll. I've spent, in some cases, 5 and 10 years getting the confidence of these people where they'll talk to me. I'm supposed to snap my fingers and give them confidence in a new group and say, by the way, I'm going away. Here's this new group. Have fun. That's not going to happen.
Mr. Barrett, if you could sort of wrap it up, appreciate it.
Okay. Mr. Douglas also mentioned at the transition plan there was no custodial care. These people are going to have to do without it. For the Alzheimer's patients and for many of the mentally ill, that will put them on the street. 50 of our 100-plus people have IHSS. Culturally, the Filipinos, among others, won't take the government's shilling. They're afraid of it. They won't get any increase in service. A number of our mentally ill people live in board and care, and the contract they are signing with the board and care says they'll go to Guardian 5 days a week. That's the only way the board and cares will keep them. They'll be on the street because there's no place else for them to go. In closing, this transition plan is utterly inadequate, and I'll just leave it at that.
Thank you. Next.
My name is Judy Canterbury, and thank you for holding this. This transition plan and the ending of adult day health care as a Medi-Cal benefit won't just affect those individuals who are Medi-Cal beneficiaries. Centers will close, and those centers oftentimes have people who are paying privately for the service or who are paid for through Veterans Administration or other resources, maybe some long-term care insurance. But those people will suffer right along with our other ADHD clients the same fate. If they have no ADHD to attend, they will be out trying to find those same few resources that our clients are expected to be able to find. A little about my background. I've been in adult day health care for 34 years. I was here when it was a demonstration project. I was here when the bill was signed, making it a state benefit. There has been years and years of research done on what the benefits are of adult day health care, what the cost effectiveness is of adult day health care. Just for an example, when they were talking about in-home support services, if an individual in adult day health care is going 3 days a week to adult day health care, that's going to cost about $900 a month. If they're getting 280 hours of in-home support services, and that support worker will take $10 an hour, say, which is not what it is anymore, but just for round numbers, that's $2,800 a month. Significantly different amounts of money. And the reason that adult day health care works for the amount of money it does is because people don't go there every day. The average individual attends 3 days a week. At one of our centers here in Sacramento, where I'm the administrator, we have a really impaired population, such as Guardian was talking about. We have 140 people coming daily to our center. Out of that number, 90% of them use a walker, wheelchair, or cane. We have 30 to 40 wheelchair patients each day. And almost 50% of our people are dealing with some sort of dementia or some sort of cognitive impairment as a result of either Alzheimer's type dementia or mental health impairments that cause cognitive impairments or traumatic brain injury.
Ms. Canterbury, if you could sort of,
Yeah.
I see you've got a long page there.
And
If you could wrap it
I
up, would
actually
appreciate it.
will give you a
And if
copy
you
of
could
my
submit it, that would be terrific.
remarks. But as the young lady said, families don't want to place their loved ones in nursing homes. And we know right off that if we have to close Rancho, we will put probably at least 20 to 30 people the next week into skilled nursing facilities. Now, they won't get there unless they go through the emergency room and the hospital to get there, but they will get there because they are that impaired. So I just wanted to let you know that I really think that if we don't slow this process down, take another look at it, see if there's some other way to look at waivering services for this really frail group, then we are going to be in a heck of a mess as a state.
Thank you, Ms. Canterbury. Next speaker, try to keep it to 2 minutes.
Yes, sir. Deborah Doctor from Disability Rights California. Thank you all for holding the hearing, and thank you for the good questions that you've asked. There's a lot that could be said, from seemingly small issues like conflating acuity with days of week of care, which is not accurate, but I'll stick to the big topics. All the people in the adult day health centers are people with disabilities. They are all covered by the Americans with Disabilities Act. They all have a right to live in the most integrated environment. We don't even know what's happened to the people who have lost services already. That hasn't been asked or answered. And another point is that moving people into managed care or into some other service does not relieve the state of its legal responsibilities. You can't transfer away your responsibility to conform with the Americans with Disabilities Act and the Olmstead decision. It's not part of your contract with the managed care. You couldn't pay them enough to have them take on your responsibility. We have offered, my organization has offered some alternatives which we've delivered to you. and we would be happy to speak about those alternatives. I want to read two sentences, which I'm grateful for the staff for having included the legal documents in the package. This court has already twice preliminarily enjoined cuts in ADH services on the basis that an across-the-board reduction in service days without provision for adequate replacement services and the imposition of restrictive new eligibility criteria would unlawfully and irreparably harm affected individuals. That was a court decision when we were talking only about reducing services or changing eligibility. We are going to court again. I hope that when an accounting is made by the Department of Finance of the costs associated with this action, that the costs of litigation that the taxpayers are paying are included in that reckoning. You have a choice. You have a chance. You can fix this before it's too late. Thank you.
Thanks, Deborah. Yes.
Hi, I'm Celine Regalia with Napa Valley Hospice and Adult Day Services, the program director there. And I just wanted to touch on a few points, and I promise not to try to repeat anything that's been said already. In the beginning, Dooley was talking about the disproportionate provision of how ADHD is distributed throughout the states. And I represent a more rural county where we're the only licensed adult day health care in our county. And I'm speaking on behalf of the rural centers because there is a unique perspective there. It needs careful attention. And one of the things that we talked about earlier was about APS and contracting and allowing rural communities, which we are really trying, Northern California, there's a couple of us that have put in for grants to try to see what we can do creatively to keep our doors open. As was mentioned earlier, some of us serve private pay. There are private pay. I access the service as a private pay consumer for my mom so that I could work full time and she could access the service. We just had a grant from our local hospital that promises us $50,000 if we can figure out a way to keep our doors open and still serve some of these people because as a community they recognize this as a safety net service. There's no replacement for care management, has been mentioned today, for the direct care that an adult day health care provides, and especially in rural communities. And I think the language that we use in these hearings is misleading sometimes when we talk about an array of services. We have already done, to your point, Senator Leno, we have started doing discharge plans for about 50 of our people. We are going through their care plans carefully. We are looking and we are finding gaps in services in all of the same areas with all the people. And if you have the conversation with the managed care organizations, no disrespect for them, what they will say to you behind closed doors is different than they'll say in public because they are the agent of the state. Mm-hmm. And just in having a conversation with them today, we're talking about how are we going to do for our local managed care, how are they going to actually do 525 assessments in a very short period of time, 45 days? It just doesn't make sense. So we were talking today how we can make that, and we're having a meeting next week. But it is a daunting task, and we are spending additional resources in our centers, additional resources that we don't have to do the right thing by our people because we want to make sure that they have what they need, that they get something, because we are what they have. And just two more points. The protective supervision is really being used in a very small definition. It's very, very difficult to get protective supervision for an IHSS participant. You have to fight and advocate to get those. But at my center, the 125 people there, only 10 of them can be independent with their just walking. They need protective supervision of a different kind. They need somebody to be with them, to support them, to make sure that they're safe so they don't fall, so they don't end up in the ER. And in the last hearing, what was also mentioned, that's not in any of the calculations that's in this transition plan, is about the caregivers. The caregivers are the reason why people, as we know, can stay in their own homes with many of these individuals that come, and their needs are not being addressed in terms of protective supervision to keep people in the community, and that needs to happen. And the fact that we provide transportation that also allows people to access service. The analysis of IHSS, we've done an analysis way before any of the stuff that was happening because we were trying to anticipate what was going to be happening with these discharge plans. On average, our participants will receive 2.5 hours more a month in absence of ADHD. They're getting a little bit more, as Debbie explained, a little bit more for personal care, a little bit more for meal prep, but it is not going to create this again, the words have been used, expanded. It's not expanded. and it's not comparable to what we provide in the ADHD setting.
Celine, if you could.
Yep, I'm done.
Thank you.
I'll wrap it up.
That's never happened to me before. No one's ever been that responsive.
I appreciate
Thank
your
you.
time.
Mr. Chair and members, Senator Leno and Assemblymember Yamada, thank you for your time, and thank you especially for your staff's time. I know they've put in a lot of work on this, and we really appreciate this. Monica Miller, on behalf of Jewish Family and Children's Services of Los Angeles and San Francisco, as well as the Jewish Public Affairs Committee of California. And just a couple of brief points. I mean, we have one client in San Francisco. Prior to going into adult day health care, she called 911 approximately 9 times a month, and they had to respond every time. Once she went into adult day health care, that no longer happens to her, and that's just one client as an example, because we are able to monitor all of her vitals, everything, and this is just from low blood sugar to I cut my finger because she has dementia and she's panic-stricken. So that just gives you a snapshot of the cost savings that adult day health care has been able to provide just to this one particular client. Another concern we have is we also offer multi-purpose senior service programs. You are looking at possibly augmenting that program with another 2,000 slots, which is great, but every year you've continued to cut that program, and we're very concerned that in January this administration, as you remember, slated that program for total elimination. We fought very hard for both adult day health care as well as MSSP. You were able to restore that program with an additional reduction. If you come back in January and continue to cut that program, these people will potentially go into the program December 1st, and once you adopt a budget in May, if you're not able to start in, I'm optimistic obviously, but in June, and you cut that program again, we're turning these clients around again, and that's something we're also very concerned about. So we don't think this transition plan works. We don't think it's very well thought out. We appreciate that the department is under the gun, but we really just think that there needs to be more time and more thought put into this. So thank you for your time today.
Thanks, Monica.
Mr. Chair, Senator Leno, Assemblymember Yamada, my name is Chris Jensen, and I'm here on behalf of Resources for Independent Living. We're an independent living center here in Sacramento, and we offer services to people in Sacramento and Yolo counties. I think it's really amazing today. I don't know of many committees that would schedule a meeting on Friday afternoon. So it's just amazing to be here. So thank you for your concern. This is a huge concern.
We were thinking of Sunday night, but yeah.
Weekends young.
Debbie still would have showed up.
Right.
There's just so much about this that it just seems to be so wrong. It's hard to know even where to begin. I like the idea, to talk about the trigger cuts. Which it looks like they're going to be pulled because the revenue's just not coming in. With IHSS in January, when the Department of Finance decides that, yeah, we're pulling the trigger, it's going to be a 20% reduction in hours across the board for IHSS. So I don't see how in the world that's going to be able to supplement any lost services from ADHC. One of the things I noticed, too, is on the last slide that was produced by DHCS, at the end, their ILCs were included as helping to supplement some of those lost services, and we don't do anything like adult day health care centers do. So I have no idea what they're talking about, and I was in contact with my executive director, and we may end up writing a letter to find out what in the world. I mean, we're a great supplement to ADHC. I think IHSS is a great supplement to ADHCs, but they in no way can pick up the slack from that. So I don't know if there's a way to repeal that legislation that eliminated adult day health care centers, but if there is, I would like to see that happen. So thank you for holding this hearing.
Thank you, Mr. Jensen.
Hi. My name is Richard Strange. I'm the site director for the MSSP program for Napa and Solano counties. I, too, would vote for the repeal of of that legislation. I'm here to support the ADHD programs. There's a program in Solano County and there's one in Napa County. They're wonderful partners for us. The Solano County program's already indicated that they plan on closing. They're waiting to see what happens at the beginning of November. As I imagine, lots and lots of the programs across the state are waiting to see what happens at the beginning of November. I probably already serve almost all of the ADHC clients in the 2 counties that are appropriate for MSSP because we have good relationships. They refer to us, and every client that comes to our program is looked at and if appropriate, is referred to the ADHC programs because we don't do what they do and they don't do what we do, and we all understand that very clearly. For us to lose ADHC as a resource would be a terrible loss for us, and we wouldn't be able to serve many of those clients. And in fact, the participants at the ADHCs who are being looked at, if the ADHC goes away, well, they would need to go to a nursing home. If they were also MSSP clients, that would still be the case because that's not a gap that MSSP can fill. So I think it's really important to look very closely. And believe me, I would love to have some slots back to MSSP. We've been struggling for years to keep this program stable. I've got more than a 6-month waiting list, and it's very difficult to keep the program going year in, year out. But I think we all have to be very realistic about what it is that's so unique and so special and done so well and so cost effectively by ADHC that it's been around this long and has been serving so many people so successfully. And it would just be a major step backwards for the state at a time when we have so many seniors coming down the line. To dismantle that infrastructure, I think, would be really unwise, and I think we'd see that in the years ahead very, very clearly.
Thank you, Richard. Thank you.
My name is Jim Provenzo. I'm a Yolo County supervisor, and I had the honor of replacing Mariko Yamada as chair of our Yolo County Aging Commission. I do not look at this as a social service program. I look at it as repaying a small part of our debt to the generation before us. For those of you who read Tom Brokaw's book, The Greatest Generation, this is the generation that fought World War II, that got us through the Great Depression, and that built one of the strongest economies in the world. It is the generation that educated me, that gave me the opportunities I have, that gave you all the opportunities you have, and built a great nation. I don't think seniors for a minute should have to even worry about these type of services being cut off, because this is, at the end of their lives, this generation has earned that benefit. I asked in Yolo County, what will this mean? Are there other services to replace it? And the response is there's nothing else to replace this level of services other than a nursing home. We have been working on the Aging Commission to fill in gaps. We have 100 volunteers working on various committees to eliminate overlaps in services, find ways to bring volunteers into delivery of services. We're doing everything we can, but this pulls the rug right out from under us, because the services provided in adult day health care are not contemplated in this plan. Thinking of the psychological, social, that's really important, because a lot of the illness is contributed to by not having companionship. Some of the conditions that we observe, they're not going to be recognized in a quickie evaluation at an HMO. How do you know somebody has dementia? If you've had it in your family, you realize you should have known 6 months or a year earlier. It's very hard to tell. If you have someone regularly coming to an adult day health care center who has a regular relationship with healthcare providers, you're going to find it earlier when there's a chance to provide medication and give that person a longer, healthier life. What about fall prevention? How many seniors do you know that need fall prevention that know that or will even admit to needing it? You're not going to get them very many to go to a fall prevention class. My mother-in-law's lived with us for 10 years, and she's fallen, but she doesn't think she needs fall prevention. But when you go to an adult day care center, they're going to provide it as part of the program. So that mix of services that they provide cannot and will not be duplicated anywhere else. And I think the plan, if it's to do anything, it would be to recreate that type of service. I think we might save money, but if we do, it's going to be because seniors die an early death. Those who become ill sooner, those who go to nursing homes and deteriorate more rapidly, those who have early onset of Alzheimer's will die earlier. But that's not how I want to save money. And I would urge you to do everything you can to get an extended period of time to plan for this. But even that is only going to be damage control. If there's any way at all of reversing this, I'm 100% behind you, and I know that everybody from every county will join you in that effort. Thank you.
Thank you, Supervisor. Thank you to my colleagues for participating. Senator Leno and I will endeavor to get the Department of Finance to answer all of these questions. And we do appreciate you coming on a Friday and staying with us on a long weekend. So happy Labor Day. Thank you for joining us. We're adjourned.